let's go to tech. And Jim, I'm going to pick up on this swath of data you seem to have aggregated over 500,000 patients in all kinds of areas, and you used a few magic words. They're very hot in tech right now. We put it on with cloud, and you have access to it, these APIs, and you have a lot of predictive stuff going on. So we're going to talk about tech, but I wanted to ask you to describe what you're doing in a little bit more detail. Like, tell us a little bit about the kind of data you have collected, and then maybe a couple of examples of how you've been able to use it.
I'll share. And this is a great segue as far as what you were mentioning, Tom, again, physician burnout. Big data finally came to healthcare the last 10 years or so, and now it's become big noise, okay? It is in the way of a patient having a relationship with their physician, provider, therapist. So that's the big challenge that we had. We thought, hey, if we have to do a better job than any of these insurance companies, and we wanted to go direct to employer contracting, all these different ideas, we had to know everything. We had to have the big data. So we brought it all in. It's fantastic. It's amazing. And we brought the data scientist in. We did the whole thing. And yeah, we're much better. Our performance is much better than any insurance company in New Jersey. They're all like, oh my God, we want to work with you. Okay? And if anybody wants to work with us, just let me know. I got some offers here and there we can entertain later. No, I'm just kidding. But the data is very powerful. But coming back to what Tom mentioned, we're not treating numbers, okay? We're treating people. And this is where you have to be very careful. The doctors are so burned out right now. I mean, we had great electronic medical records. I don't care which one you use. I went through 6 of them in my practice because I hated every one of them. They're transactional tools that cost too much money and don't help you become a better physician. Okay? You want to contest me on that? I'll show you. Okay? But we're stuck with this, and of course we have to document in order to get paid, in order to show it our view. So the doctors are burned out from the compliance, the electronic medical records they have to use, the fact that they can't even look at a patient when they walk in the room anymore. They got to have their head buried in that laptop. Or it's horrendous. Especially for the relationship with the patient. So what we did with our data is we filtered out the noise. We did all the pattern recognitions. We did all the prioritization of patients. We did all these things. And we found that when the doctor had that patient, number one, most important thing we did, we found which patient should be in that doctor's schedule today but isn't. That's critical, especially when you get to proactive care. So you find the people who need to be in that office. Then when the doctor goes in the room, there's a little pop-up that overrides their EMR, because the EMR just gets in the way. But, and I'm sorry, the EMR, but it's going to kill me on this. But a pop-up comes up and shows, okay, doctor, if you had 1 extra minute today with this patient, here's the most important thing you could do. If you do this one thing, it will have the greatest impact on this patient's health and on their outcomes. So it's like, whoa. Yeah, the doctor all of a sudden became smart. And when I said earlier, who's a good doctor, bad doctor? There are no bad doctors, okay? Every doctor wants to be a better doctor. But we haven't given them the tools. The EMRs fail. So this is the right way of it to bring insights into the workflow. Help them with that. At the same time, we do, here's the insights into their screenings that they should be doing. Here's their depression screening that has not been done yet. And Dr. Barr, you better do that today. And all these other things. So it's great, but still, then the list gets long. So then comes the collaborative care model. And this is how you then share information with a partner, like a behavioral health platform, that I can then offload those screenings, okay, to an entity that has professionals. that have devised, this platform that will do my depression, anxiety screenings, all my screenings for me. All of a sudden, I'm unburdened as a primary care doctor. I don't have to do them. My staff doesn't have to do it. Then all the education and coaching I used to have to do for all the behavioral health conditions, which takes a lot of time. I don't have time. The technology platform, does it for me. Oh, and then the patient has an acute assessment that shows that they're at risk. And like, oh my God, what do I do? I send them to the emergency room. Oh, yeah. No, the platform is people, professionals who can get in touch with that person right away. They're cared for. So this is a combination now of I am unburdened as a physician. My time is more free to look at a patient instead of have my head buried in a computer. And I have a team member, not a vendor from the insurance company who is like 1-800 mental health. That's what I used to have to do. Now I've got a team member. My practices are meeting right now with the care managers face to face. They are teammates. And now the patient gets the interaction. And they're saying, oh, well, Dr. Barr wanted us to check on you for this, and Dr. Barr wanted us to check on you for this. Oh, that's great. I'm so glad, Dr. Barr, you are working together. This is the way healthcare can be. Smarter, the insights that I need, boom, the ability to collaborate with professionals outside my practice, yet fully integrated, because I'm the first point of contact for this patient usually. I'm the one they trust most, and we're going to leverage the hell out of that relationship to make it work.
That's very cool. Tom, maybe you can pick up on the tech aspect of this conversation, particularly given the NeuroFlow angle.
I probably have something to say about that. Technology, when most physicians and a lot of healthcare providers in general think about technology, it just often can feel like another thing between me and my patient. And actually, that's a fallacy. It's true that with electronic health records, 100%. I've been there, done that with Epic. Jim and I worked in the same system.
You're not supposed to say what EMR it was.
We're all friends. It's not just Epic. It's every electronic health record. And as good as they are, or they are not terribly user-friendly. They're very clunky. They are sort of a necessary evil in many ways. We recognize that. But technology is there to help facilitate the interaction that healthcare providers have with their patients. It's a synergism that actually facilitates that human interaction. Now that may sound odd. How does technology leverage the relationship so that patients get better, so that providers like what they're doing a lot more? The joy of medicine comes back into it. I've seen this over and over again. So I've been, well before I was at NeuroFlow, I was engaged in research and models of care, population-focused models of care. Jim called, the collaborative care model, which is this model that's been around since the 1990s. I was fortunate my mentor was the guy who started that model, that uses limited resources. Psychiatrists that are very, very limited. 77% of counties in the United States have a severe shortage. 55% of counties have no psychiatrists at all. I mean, we don't have enough psychiatrists. We don't have enough mental health professionals. So we've got to come up with models of care that leverage those limited resources. And we've got to use technology in order to make everyone more efficient so that so providers, whomever they may be, can really spend a lot more time with patients so that they have the information they need to make the decisions they need to make without having to do an extraordinary amount of work away from the patient in order to make that happen. Over almost 2/3 of the time that physicians spend, I think I'm getting that right, is spent not in direct patient care. It's spent in documentation and administrative tasks. It's really remarkable. Really remarkable. So technology is a way to bridge and really build on that connection between the patient and the provider. And I just can't emphasize that enough. And part of it is it's a complete conceptual leap for providers to think that way. So what we do at NeuroFlow in terms of using technology is that we can automate workflows. We can take tasks that required multiple team members on a primary care team, let's say, and multiple steps in order to get a screen. And I used to do this regularly. And it was incredibly time consuming. It wasn't feasible to scale these models where you would do massive screening. So you can use technologies. What we do here, you can use technology to do remote screenings. And guess what? When you do those remote screenings, they can be done in the comfort of someone's home, which actually can lead to a more realistic assessment of how someone's doing. That Heisenberg uncertainty principle when patients present to a doctor's office, the white coat hypertension, that people present differently in front of their doctors or their providers than they do in the comfort of their homes. There's a whole science called ecological momentary assessment that speaks to the importance of addressing and evaluating how people are doing in the comfort of their own routines and homes. And then, on top of that, you can use technology, not to replace human beings, but human beings can't be physically present all the time. So you can use technology based on those assessments to trigger self-management tools. So if you don't score positively for depression or anxiety or whatever, there are tools for positive psychology and resilience and insomnia and a whole range of things that people may be experiencing. And if you are scoring positively, there are self-management tools that are intended to augment the care they're getting from a psychotherapist or whomever's treating them that allows the practice to extend into the comfort of patients' homes. And it allows the integration of psychiatry into primary care settings. You've heard that primary care in particular, and it's not just primary care, it's subspecialty care, it's oncology, it's GI, it's a whole range of settings, it's acute care settings as well. But the reality is there is so limited time and there's such a push to be as productive as possible that these things don't happen. So when you can incorporate technology to do the screenings, to extend the work of the practice through this technology into patients' home and to reinforce the relationship between the provider and the patient, the care gets better. So the irony here is that the outcomes, patients get better, physicians feel better, costs ultimately, and again, at NeuroFlow, we're not directly driving those costs. We support evidence-based models of care. We're standing on the backs of giants, and that we support these evidence-based models of care. We just our technology allows us to integrate and scale those models of care that we know after 90 randomized controlled trials will produce really wonderful results. Up until 2017, there was no way to pay for that. And fortunately, that's now accelerated. So Medicare came out with G-codes in 2017 that support this model of care called collaborative care. That's just one model, by the way. It's the most well-established model to integrate care into medical settings. 2018, there were CPT codes, there were fee-for-service codes, and now, fortunately, we have Jim, people like you who are looking at the data and recognize the importance about the savings, because when you start treating the underlying psychiatric illness, the utilization goes down, the ED visits go down, patients get better, the system runs more efficiently. You're not having so many patients with these medically complex patients with psychiatric comorbidities who wind up coming to the hospital and staying for an exceedingly long time, taking up beds that need to be filled by patients who have acute medical illness. So the system works more efficiently. And we're moving increasingly quickly, actually, in that direction. And there are innovations. There's the Center for Medicare and Medicaid Innovation and Medicare that's doing interesting stuff with value-based care arrangements. We're increasingly moving in that direction. Is it a waterfall right now no, it's a trickle, but it's catching on, and COVID has rapidly accelerated that. So I think
But what are the constraints to adoption? What could make it go faster?
So the things that can make it go faster, one, part of this comes down to dollar and cents, and we need to make sure that we're supporting the providers out there, the health systems out there to adopt these models, because there are upfront costs. There have been studies looking at this, and there are ways of supporting that. And there's legislation. For example, we just did a panel discussion in Capitol Hill in support of legislation that was bipartisan in Congress to increase Medicare reimbursement, and the hope is that if that gets through, that there will be an alignment of payers to increase Medicare reimbursements to really cover the cost of implementation of these programs. Because the health systems say, well, that's great, we think this is great, but we just don't have the dollars to do this. So one is reimbursement. Two is education. These models of care and the technology and what these things can do, there's a lot of reflexiveness in terms of people saying, no, I can't do that. I'm burned out. I can't take on another new task. I can't take on something new. So some of it is education. You don't learn this stuff in medical school. And I don't know if there are any medical students here, but even now, it's not. I was talking to a medical student at Temple just a short while ago, and he still is not learning about these population-based models of care. It's remarkable. Active medical student. So there's a lot of work we need to do, but we're getting there. And we I and others are going out and teaching medical students and others. I think we're getting there. There are impediments, but I think because the demand is so great, because the need is so great, because there's greater recognition, because, Amy, to your point, there is such stigma, but the stigma, I would like to think, is getting better, that there's more and more discussion about this. So I'm very optimistic that we will get there, and we're seeing that. Certainly we're seeing it at NeuroFlow. I'm seeing that over the course of my career in the past 5 years, 6 years, huge uptake.